Hello, I'm Harriet Esdaile. I'm one of the diabetes and endocrinology registrars based at Charing Cross Hospital. And today I'm talking about optimizing treatment strategies for genetic disorders. Hopefully it will become more apparent why there's a cartoon of a clock and a woman present on the screen. So really this is a talk which revolves around the case of a 23-year-old woman with multiple endocrine neoplasia type 1. So her father had multiple endocrine neoplasia type 1. At the age of 13, she underwent genetic testing and was found to have a mutation in MEM1. Following on from that genetic diagnosis, she's been diagnosed with a microprolactinoma. She has primary hyperparathyroidism, and she has had an insulinoma resected. So she's had a subtotal pancreatectomy. And we'll return to her case a little bit later. So multiple endocrine neoplasia syndromes are tumor syndromes of variable neoplastic patterns, characterized by the development of multiple endocrine tumors. So MEM1, or Vermeer's syndrome, is one subtype, and it's a rare, highly penetrant autosomal dominant disorder. So the occurrence of multiple adenomas of the endocrine glands in humans has been recognized since at least 1903, when Jacob Erdheim, an Austrian pathologist, described a pituitary adenoma associated with parathyroid disease and thyroid nodules. In 1954, Dr. Paul Vermeer published a paper entitled Genetic Aspects of Adenomatosis of the Endocrine Glands in the American Journal of Medicine. And he made three main observations. So the first was that the syndrome of adenomatosis of the anterior pituitary, the parathyroids, and the pancreatic islets was observed in a family where the father and 4 of the 9 siblings were affected. It is assumed, therefore, that the syndrome in this family was caused by a dominant autosomal gene with a high degree of penetrance. The gross and microscopic findings in the parathyroids and in the pancreas differ from those seen in the more common single adenomas, and the therapeutic approach therefore has to be different in the 2 types of cases. And thirdly, that peptic ulcers of the stomach and of the duodenum are frequently found in patients suffering from the syndrome of adenomatosis of the endocrine gland, and this may be looked upon as another manifestation of the abnormal gene. So if we then fast forward 22, 23 odd years, we have identified the mutation we've identified the gene essentially that's causative for multiple endocrine neoplasia type 1. And that was identified by Professor Thacker at Hammersmith Hospital. So the MEM1 gene was identified on chromosome 11q13, as 10 exons that encode for 610 amino acid protein menin. And essentially germline mutations lead to a loss of heterozygosity. And this has been reported across the whole coding region. There's no clear genotype-phenotype correlation from mutation type or location. And obvious inactivation of menin is predicted by nonsense frame shift, splice mutations, and large deletions. And these will lead to truncation of menin. So menin is a tumor suppressor. It's been labeled as a scaffold protein connecting transcription factors to histone modifying protein complexes. So it interacts with several classes of transcription factors listed in the left panel, and then with several histone modifiers to repress the transcription of specific genes associated with the regulation of cell proliferation. So just skipping on to clinical aspects. So MEN1 associated tumors, we typically think of the 3 Ps. So that's parathyroid adenomas, pancreatic tumors, and pituitary adenomas. there are a number of associated tumours which you can see in the green box. And then the basis for MEN1 diagnosis may be genetic, may be familial, so a patient with one MEN associated tumour. And these are generally parathyroid, pituitary or pancreatic, and a first degree relative with MEN1, or clinically a patient with two or more MEN1 associated tumours. So management is really about surveillance, targeted medical therapy where appropriate and where hormone suppression can be achieved, and then ultimately surgery. However, surgery is difficult, and that's because tumours, with the exception of pituitary neuroendocrine tumours, are usually multiple, making it difficult to achieve a successful surgical cure. Occult metastatic disease is more prevalent in MEN1 patients with neuroendocrine tumours than in patients with sporadic endocrine tumours. And MEN1 tumours may be larger, more aggressive, and more resistant to treatment. So let's just think a little bit about this lady's primary hyperparathyroidism. So these are the guidelines for the management of asymptomatic primary hyperparathyroidism in patients who generally don't have MEN1. So generally will have a parathyroid adenoma. So we can see here that the key indications for surgery would be evidence of end organ damage. So osteoporosis, a vertebral fracture, evidence of end organ damage in the kidneys, with evidence of renal failure or kidney stones, and a serum calcium that's consistently raised. But what about in MEN1? So we know that the majority of patients will have full gland hyperplasia, and it's often the first clinical manifestation of MEN1. So the youngest reported cases are at the age of 4. So these patients have a much longer exposure to the harmful effects of PTH on bone. Surgical removal of the abnormally overactive parathyroid glands in MEN1 patients is the definitive treatment, but timing and extent of surgery is debated. So our patient transferred her care to us in 2019. As I say, she had primary hyperparathyroidism, and this had been managed conservatively with no surgery to date at that time. She had a DEXA in 2017 with a lowest Z score of minus 0.2. So that's essentially bone that's in keeping with the bone density expected for chronological age. Her creatinine clearance was unremarkable, and she'd had a normal renal ultrasound in 2019. So just looking at her figures, we can see in August 2019, her calcium is just above the upper limit at 2.69 with a PTH of 16.1. Just before lockdown, her calcium creeps up to 2.93. And it comes down a little bit with an increase in fluid intake, but by the end of March, it's still 2.8. And because of the concern about the availability of blood tests over the lockdown, there's a decision to start cinacalcet, which is a calcium mimetic. So this controls her calcium relatively well. We can see for the next 15 months, her calcium is either in the normal range or elevated, that reading of 2.70 in December 2020. In June 2021, she comes off the cinacalcet, and we can see the subsequent calcium readings have stuck at around 2.7. Her PTH is in the low to mid-teens, and her vitamin D is replete. She also goes on to have 2 DEXA scans, one in December 2020, so that's 3 years after the last scan, and then another scan just actually last week. So this is the scan from 2020. So we can see that actually her Z score is now minus 2.9 in the lumbar spine. So that's bone mineral density below what would be expected for her chronological age. And again, we can see Z scores that are beginning to fall at the radius, so minus 1.7, and then at the femoral borderline, minus 2. And then this is her scan from last week. We can see that there's been further bone loss at every region. So this patient was referred to Professor Palazzo following that first DEXA because of the concern about the low bone mineral density for chronological age for consideration of parathyroid surgery. So he had a discussion with the patient, and there was a discussion that we could consider a subtotal parathyroidectomy. So that's removal of 3.5 parathyroid glands, but she would likely need further surgery. And the outcome was that she wanted to hold off at present. So on the one hand, we have a patient who, she's 23, she's already had previous surgery for the insulinoma. She wants to avoid multiple neck surgeries, doesn't want surgery at present. And her father really struggled with his hypoparathyroidism in the context of his MEM1. And it's noted that actually, as she has no pregnancy plans at present, there's no need to rush. However, at age 23, she has a reduced mineral density for her age, albeit with no history of fractures that we know of. And if surgery is delayed, will she ever achieve her peak bone density? So over to you. I'm going to ask you what you think we should really advise this patient to do right now in terms of her surgery. So, Prof. Miran, do you need to share?
I will do that. I will do that now. So those of you who haven't voted on the first question, you'll need to join, but those of you who have voted on the first question can just answer straight away because it'll be on the device that you've used. So there are the 4 options. Do you think, so if you haven't joined, could you go to menji.com and put in that code? In fact, I'll put it in the chat just to make sure that people have it. So you go to menji.com, put that number in. So do you think we should leave her alone, no surgery? Or do you think we should take 3.5 glands out and leave her with a little bit of parathyroid tissue? Or do you think we should just take 2 of them out, let's say, less than subtotal, or take all 4 out? And let me put a 10-second countdown for the rest of you. There's 2 more people who are definitely connected who can vote. Hang on. Okay, Harriet, what do you think about that?
Okay, so I guess some spread in the response. I guess did I slightly give it away by talking about what we were going to recommend?
Not at all. I'm noticing that nobody wants to leave her alone. Okay, do you want to share your screen again?
Yeah. I think I'm going to.
Yeah.
Back.
Yes, there.
Apologies. Okay, so the recommendation would be for a subtotal parathyroidectomy. So as I mentioned, the removal of 3.5 glands. And this essentially allows the patient to continue to have some PTH on board, although we know that it will, in most patients, so between 40 to 60% of patients, somewhere between 10 and 12 years after surgery, there will be a persistent or recurrent hypercalcemia requiring further surgery. But the hope is essentially that you're avoiding a total parathyroidectomy and rendering the patient totally hypoparathyroid, reliant on large doses of activated vitamin, well, doses of activated vitamin D and calcium for the rest of their life. Less than subtotal parathyroidectomy, where there's just unilateral removal of 2 parathyroid glands, was considered at one point, sort of 10 years ago, I think, as a surgical strategy. But this really relied on pre-operative imaging. And we know that in this group of patients, pre-operative imaging is not sufficiently reliable to justify unilateral exploration, with actually 85% of patients having enlarged contralateral parathyroid tumours that were missed. So moving on to her microprolactinoma. So this was diagnosed at the age of 15 with a prolactin at diagnosis of approximately 3,000. She's had 2 pituitary MRIs, one in 2015 and one in 2019, showing an unchanged 5mm by 3mm microadenoma. And she'd been treated with cabergoline for a period of time, so a dopamine agonist, previous to the time that she transferred her care to us, but actually was no longer on the cabergoline. And her prolactin was maintained really between 1,000 and 2,000. And she was having withdrawal bleeds on the oral contraceptive pill. So just looking at her prolactin and her gonadal axis. So again, when she transferred to us, her prolactin was around 1,000. She was on the pills. We can see that her estrogen, LH, and FSH are all suppressed. And then she decides to come off the pill in December 2019. We give her a little bit of time, but 5 months later, she's not had a period. So there's a decision to start cabergoline. And she starts this properly in July of 2020. That's approximately just over a year and a half ago, after her university finals. And we can see actually that her prolactin has begun to come, well, it's now actually in the normal range on 2 occasions. So with those readings in June and December, so our cutoff is 500. And that's with increasing doses of cabergoline. She still hasn't had a period, but we can see for the first time that really her LH and FSH have begun to recover as of bloods taken just last week. So in light of this, I wanted to again ask you what you thought that we should do. Should we start her back on the oral contraceptive pill, so something containing ethanol, estradiol? Should we start thinking about HRT, for example, sandranagel with utrogastran for withdrawal bleeds? Should we watch and wait on the same dose of cabergoline? Or should we watch and wait but increase the dose of cabergoline?
Okay, if you want to vote now, the options will be on your device. I'll give you 10 seconds, I think. Come on, one more vote, quick. Okay, it's still 7. Okay, so a bit of a spread there. Sandranagel, 3. Watch and wait, 2, and watch and wait, but increase cabergoline. Okay, do you want to share again, Harriet?
Okay, so we discussed this case last week at the Multidisciplinary Endocrine Symposium, really thinking about, although we know that this lady has primary hyperparathyroidism, how can we be sure that the DEXA appearances and her low bone mineral density for age are a result of her primary hyperparathyroidism. So how much of this do we think will improve once she starts having periods or having some exposure to estrogen? And how long really do we want to wait once she starts having periods or having some estrogen on board? And I think there was a discussion that actually looking at her DEXA scan, the area that seemed to be mostly affected or with the lowest bone mineral density was the spine. So that's typically trabecular bone, which needs the estrogen. And that you would expect in primary hyperparathyroidism that you would have loss at the distal 1/3 of the radius. So there are several options, I think, with this patient. I think the consensus last week was that we could watch and wait and see what happens once her periods come back, given that we've now seen a rise in her LH and FSH, and actually consider another DEXA scan in a year, and then reconsider the criteria for surgery for her parathyroids. Is there anything that you wanted to add, Professor Miran?
That's really clear. I think it's interesting that no one chose the pill. I'm glad because we're worried about her bones, as you'll say, and the pill is not as good as HRT on bone. Obviously, it's a contraceptive. But no, do you want to carry on?
So mentioning pregnancy, so we talked about how pregnancy wasn't really, she didn't want to get pregnant at the moment, and therefore we had a little bit more time. In terms of MEM1 fertility and pregnancy, generally there is adverse fertility related to an uncontrolled prolactinoma because of the suppression of your gonadal axis. But really, in terms of pregnancy, there are a few published outcomes regarding pregnancy in this population. And then just thinking about generally primary hyperparathyroidism in pregnancy, we really try to avoid somebody going into pregnancy with primary hyperparathyroidism. And that's because there are a number of really adverse effects, both to the mother, fetus, and to the neonate. So these generally appear related to the degree of hypercalcemia. Maternal hypercalcemia will lead to reduced fetal PTH, resulting in neonatal hypocalcemia. And there's a significantly increased miscarriage rate observed with an adjusted calcium really above 2.8 or 2.85. So if you do have a patient who has primary hyperparathyroidism in pregnancy, generally we avoid the use of cinacalcet, and if required, we would plan to do a parathyroidectomy in the second trimester. And then just at the end, I'm just going to mention this lady's gut neuroendocrine tumours. So at the age of 14, she'd had an insulinoma resected. She then went on to have a nucleation of 2 lesions in the pancreatic head, one staining for insulin and the other for glucagon. She had further imaging, she had the endoscopic ultrasound, just showing 2 very small lesions in the pancreatic head, actually too small for a nucleation, with essentially normal hormones, and an MDT decision to monitor annually with an MRI, with the last MRI of the pancreas in 2021, with no lesion identified. So we effectively think that she's in remission at the moment. Okay, so that is the end of the talk.
Thank you very much. Any questions from anybody? That was very clearly presented. Do you want to just go back to the DEXA scan picture that you had? That was quite clear, I thought. Yeah, that one. because on that you can see it's all going downhill. And really for this patient, it's all about her bones and the two causes of her bone loss. She's got two of them. She's got hyperparathyroidism and this prolactinoma, and they're both attacking different bones in different ways. I think that rate of fall of the distal radius is a bit faster than the others. So I'll be keen to think about a pathoidectomy. Professor Lightstone, your hand's up.
My hand's up. How polite am I? A really nice and really difficult case. How do these patients deal with it psychologically? I mean, it must just be like living under the sword of Damocles, and then your children are likely to inherit it, etc., etc. It's a bit grim. She's only 23.
I know. And in fact, and of course, we have whole families in our clinic now with these conditions. I mean, this is less bad than many other aggressive genetic disorders. But there is the pancreatic cancer. It's not a standard cancer, it's these hormone-producing ones. The parathyroid and the pituitary we can control quite well, and the outcome problem is bone. So it's a long way away, but you've just got to watch things like pregnancy. So she can't, I mean, she can, of course, become pregnant, but if she does become pregnant, she mustn't be hypercalcemic. So we have to do a pathoidectomy, and Palazzo doesn't want to operate more than once if possible. So he wants to do 3.5 in one go. He wants to wait as long as possible so he leaves behind the smallest one. But of course, we're sitting here watching her bones disappear. So that's very tricky. So you're quite right. There is a society, we have AMEND, on which I'm one of the trustees, the Association of MEN Therapies, and there's huge families who all turn up to meetings and discussions, and they're very helpful for that. In terms of molecular therapies, not for MEN itself, we do have pre-genetic diagnosis in pregnancy, and we do have the option of IVF, and you can, because it's dominant, you can select, and there are some patients who are doing that and choosing MEN1 negative children. So that is now happening. It's not a fatal condition, and what we do a lot of is monitor and then jump as soon as we need to and take out the parathyroid. One of the problems that we used to do, which is with hindsight probably wrong, was take out all 4, because then you can cure them in theory. But I can tell you that hypoparathyroidism is worse, because calcium, and if you've taken calcium, they're huge chalky things, and you become dependent on 16 tablets a day. If you don't take it, you suffer. So that's a problem. But there's no other progress on therapy directly to MEN1, or in fact the other one that we've not talked about, MEN2. We have a lot of patients here because of Raj Thakker's work when he was here sequencing patients and families, and of course they still come to the clinic even though he's moved on. Good, thank you very much. No other questions. Do you want to stop sharing, and then Florian, do you want to share your screen? Thank you, Harriet, that was really excellent.
Thank you.
Okay, so our second case is Dr. Florian Wernig, and he's going to tell us, and we're still using Menti, okay? So we've got 2 more, you're all logged on to Menti, I hope. So we're going to look at the different treatments for subclinical Cushing's, and he'll explain what that is.
Thank you. Can you see the slides?
Yeah, now I can, just to say that we can see your next slide as well. So what you should do...
Oh, no, I didn't want that.
That's all right. So if you're at the left, you can change it to...
See if I can do that. Oh, it's this one. It's not. That's better.
Yes, perfect.
Yes, thank you very much. So I would like to talk about subclinical Cushing syndrome, and in particular about the clinical trial we are currently carrying out at Imperial at Hammersmith Hospital. I would like to start with the case. So this is a 62-year-old woman with an 8-year history of hypertension. So a very common presentation in our clinic. And she was referred because she presented to a different hospital with abdominal pain. She was given a CT scan, which identified a 2.5 centimeter wide adrenal adenoma. That's what the adenoma looked like. So you can see it here indicated by the yellow arrow. And I also measured the mean Hounsfield unit, which may be difficult to read. So it says 31. So that means Hounsfield units of 31, this is an indeterminate nodule. Anything less than 10, Hounsfield units less than 10 counts as a lipid-rich nodule and is usually benign. 31 needs some follow-up because it may not be entirely benign. So a question to the audience, to the endocrinologist and non-endocrinologist, what would you do next? So you've got a 68-year-old lady with a history of hypertension, presents with a completely different reason to hospital, has this incidental finding of a 2.5 centimeter adrenal nodule. So would you refer for adrenalectomy? Would you do a PET scan to rule out that it's not malignant? Because I just told you it's indeterminate. Or just an interval CT, or test for hormone hypersecretion?
Let me give you 10 seconds. We've got 7 votes, which is the number we've had up to now. But let me see if we can get, we've got 8. Come on, 1 more, guys. Same Menti code. What would you do next in this patient with that adrenal lump? Excellent, we've got 9. Let me show you the answer that you've chosen.
Okay, well done. So that's the right answer. I need to share my screen again.
Yes, please.
I mean, the PET scan is not entirely wrong, so I'll get back to that. It's so I give you some more clinical history. So this lady has a history of asthma and hay fever, but no other significant past medical history. She's a retired personal assistant, doesn't smoke, and drinks minimal alcohol. She's got 3 adult children. And the important other feature of her history is that she gained a significant amount of weight during the past 8 years. Her BMI when she first presented to our clinic was 37, and she was significantly hypertensive with a blood pressure of 168 over 115 millimeters of mercury. She's come to an endocrine clinic with an indeterminate adrenal lesion, so we would make sure that she hasn't got features of hypercortisolism. And the sort of classic features you all know about that would indicate Cushing syndrome are abdominal striae, in particular purple stria, skin fragility, so easy bruising, and proximal myopathy. Another feature is osteoporosis. That's also something we often check by doing a bone density scan. So this lady didn't have any of those features. She was taking 2 antihypertensives, losartan and benzoyl in addition to other medications, including inhaled steroids for her asthma. And she was intolerant of amlodipine and doxazosin. So we did exactly what most of you suggested. So we checked for hormone hypersecretion. And one of the tests, jumping the queue slightly, once we had an elevated aldosterone to renin ratio, which indicates possible aldosterone secretion from that adrenal lesion, is a confirmative test, the so-called saline suppression test. So if we suspect primary aldosteronism, Conn syndrome, aldosterone secretion, autonomous aldosterone secretion, we try to confirm that by giving a patient 2 liters of saline over the course of 4 hours and try to suppress the aldosterone secretion. And as you can see, the initial aldosterone for this patient was 450 picomoles per liter, and it dropped to 110 picomoles per liter, which rules out primary aldosteronism, so everything less than 120. She had a suppressed renin, but it was detectable, so it wasn't fully suppressed, which also makes us a bit suspicious that it may not be primary aldosteronism. And of course, we stopped interfering medications before we did that test, and she was just taking one antihypertensive, verapamil, which doesn't interfere with renin or aldosterone levels. So the next test we did were checking her plasma and urinary metanephrines to rule out that she doesn't have a adrenal medullary lesion producing excess catecholamines that would lead to hypertension, and measuring metanephrines. So an adrenaline and noradrenaline product is the gold standard test, and they were normal in her case, so we have ruled that out as well. We then carried on to investigate to see whether she has got cortisol secretion from this adrenal lesion. And the gold standard test is so-called overnight dexamethasone suppression test. So patients are being given 1 milligram of dexamethasone at night, so at 11 o'clock, and they return to the hospital at 9 o'clock for a cortisol level. And if normally we would expect cortisol to be suppressible of less than 50 nanomoles per liter. So dexamethasone is not detected by the assay, and we would only detect endogenous cortisol. So most patients who don't have autonomous cortisol secretion would have a fully suppressed cortisol when measured the next day. And to be absolutely sure, we admitted her for a so-called low-dose dexamethasone suppression test, where patients are being kept in hospital for 2 days and being given 6-hourly dexamethasone. We measure the cortisol before and after, and we can also measure her ACTH. And again, she failed to suppress cortisol of less than 50. It was 105 nanomoles per liter with a fully suppressed ACTH on day 2, which suggests autonomous cortisol secretion, which is not ACTH dependent. Furthermore, she had borderline diabetes with a HbA1c of 41 millimoles per mole, and her cholesterol to HDL ratio was controlled on a statin. So what would you do now? And I should also add that by that point, she also would have had an interval scan. So I haven't given that option. So we have actually excluded that this lesion is malignant. So the malignancy risk of this indeterminate lesion is out of the equation. So what would you do? Would you refer for an adrenalectomy, start metarabone, which is a cortisol-lowering agent, optimize her blood pressure, blood glucose, lipids, and promote weight loss, or just monitor and repeat the overnight dexamethasone suppression test in 6 months?
Right, all. No one's voted yet. 1. Let me give you 10 seconds. So adrenalectomy, start metarabone, optimize, or repeat the test. Okay, only 4 voted this time, so whoops. Show. So no one wants to wait. Okay, do you want to share again?
Yeah. Okay. I mean, none of the options is necessarily wrong, because we haven't got much evidence, as I will point out over the next 15 minutes or so, and what to do. And that's exactly why we need to conduct more clinical research. So just quickly about adrenal incidentalomas. These are very common findings on imaging, and the definition for an adrenal incidentaloma is a clinically unapparent adrenal mass of more than 1 centimeter, which is detected during imaging performed for reasons other than suspected adrenal disease. So like this lady presented with abdominal pain, incidentally is found to have an adrenal lesion. It is currently not recommended to investigate lesions of less than 1 centimeter unless there's a clinical indication. That would be if a patient presents with hypertension we are suspecting Conn syndrome, for instance. The prevalence increases with age, as one would expect, and it very much depends on what kind of studies you look at. So whether that's autopsy studies, radiological series, or surgical series. And it affects about 2% of the general population, and at least more than 7% of those over 70 years of age. On the other hand, it is rarely seen in young patients of less than 30. Up to 10% of adrenal incidentalomas will present with hormone hypersecretion. And the general recommendation is to rule out catecholamine excess and cortisol secretion. It's also recommended to rule out primary aldosteronism, Conn's syndrome in patients presenting with hypertension and hypokalemia. As we all know, cortisol and glucocorticoids are secreted from the zona fasciculata under control of ACTH from the anterior pituitary. And the amount produced per day is about 10 to 20 milligrams. Autonomous cortisol secretion is defined as ACTH-independent cortisol excess without clinical signs and symptoms of overt Cushing syndrome. And the difficulty is that it can be really difficult to diagnose because the cortisol secretion may just be very marginally elevated, and patients may be fully asymptomatic and may not have any features or comorbidities related to cortisol hypersecretion. And when we test, we really have to be careful because the false positive rate is very high, and it is a big risk that we actually pick up a so-called false positive. And that is because obesity, diabetes, and hypertension are very prevalent in the general population. Also, there's other reasons why the cortisol may be elevated, such as obstructive sleep apnea, or there may be a problem with the method how we detect it itself, such as reduced dexamethasone absorption or increased dexamethasone metabolism. Current guidelines recommend screening for Cushing syndrome. So that is for patients who actually present with clinical Cushing syndrome to use at least 2 out of 3 highly sensitive screening tests. And that includes late night salivary cortisol, so using the diurnal variation of cortisol, or 24-hour urinary free cortisol levels, in addition to either an overnight dexamethasone suppression test or low-dose dexamethasone suppression test. So the combination of the 2 tests yields the highest sensitivity and specificity. However, for autonomous cortisol secretion, patients not having clinical symptoms of Cushing syndrome, there is no gold standard. But it appears that the overnight dexamethasone suppression test performs best. But again, a false positive result is still more likely than a true positive. 40 years ago, a French group described the first case and published the first case of a patient with no clinical features of Cushing syndrome who failed the dexamethasone suppression test, so very much like our patient. And since then, we learned that in those patients who have biochemical evidence of cortisol excess, hypertension, insulin resistance, obesity, dyslipidemia, osteoporosis seem to be more prevalent, and they also possibly have increased mortality. However, if we look at studies, so this is a recent analysis of 6 different studies looking at cardiovascular mortality and cardiovascular events in patients with adrenal adenomas with autonomous cortisol secretion versus those with so-called non-functioning adenomas. There seems to be an increased trend, so 16.7 versus 6.7%, and also increased mortality. But there was a big problem with heterogeneity among the few studies of different definitions of autonomous cortisol secretion, and there was no adjustment for common confounders. And if you look at the natural history of autonomous cortisol secretion, then it seems to be the case that autonomous cortisol secretion virtually never progresses to florid Cushing syndrome. And that comes from a big analysis of more than 4,100 patients, looking at all various, mostly retrospective clinical case series and studies we have to date. The risk of cortisol secretion increases with size of the adrenal lesion, as one would expect, and 2.4 centimeters seems to be a cutoff where cortisol secretion is more likely. So the logical thing from what I told you so far would be to try to reverse that and remove the source. However, up to now, we have no robust evidence that reversal of autonomous cortisol secretion actually improves outcomes. And studies so far are mostly retrospective, include small numbers, and were uncontrolled. And there seems to be a trend that all the metabolic parameters improve, but we don't know that yet. One of the international experts in adrenal research, Professor Wernig, wrote in 2000 that it remains doubtful whether patients with subclinical Cushing syndrome benefit from adrenal surgery because the progression from subclinical disease to overt Cushing syndrome occurs in a minority of cases. And then he also concludes that adrenal surgery has significant morbidity and mortality. This was in the year 2000. That must be taken into account when considering this option. The newly developed endoscopic adrenalectomy associated with low morbidity may justify earlier intervention. And since then, there have been huge advances in adrenal surgery. And if you look at that slide and compare the days in hospital, the length of stay of patients undergoing open adrenalectomy versus days undergoing laparoscopic adrenalectomy, then we don't need randomized controlled trial to actually see the big advantage. So the length of stay is from almost has been reduced from almost 2 weeks to 1 to 2 days in hospital. And up to now, there was one clinical trial, randomized controlled trial, comparing surgery with conservative management for subclinical Cushing syndrome, published in 2009. The problem with that trial was that the study period was very long. It was 15 years. During that period, 45 patients were randomized to surgery and observations. And hard endpoints were lacking, so the outcome parameters were quite subjective. And significance, once they have analyzed all the data, was only achieved for hypertension, which is very much in keeping with what previous observational studies showed. Current guidelines currently give no clear recommendations. So that's the latest guideline, how to manage adrenal incidentallomas, published in 2016. And in that guideline, actually, adrenal lesions are divided into 3 categories. So those who fully suppress cortisol following an overnight exercise suppression test, patients who fall in this middle category with a cortisol level of 51 to 138, and those with a cortisol of more than 138 nanomoles per liter. But if you look at, this is just highlights that our patients would fall in this gray zone in the middle. But if you look at the 4th row from the top, then this is consider surgical removal. And for most of them, it would say no. Even if a patient fails the dexamethasone suppression, like our patient, there's no clear recommendation for surgery. And even with higher cortisol levels, the recommendation is only more often. So it is a very vague formulation, actually, what to do. It doesn't really guide us. And this is one of the reasons why we decided to participate in an international study where patients are randomized to surgery versus adrenalectomy. And this study was designed initially by colleagues at the University of Lund, and there's other centers, mainly in Scandinavia, participating in addition to our center. The inclusion criteria are adrenal tumors with evidence of biochemical hypercortisolism, And that is defined by failing an overnight dexamethasone suppression test, plus a further criteria, either low ACTH level, low DHES, or loss of circadian rhythm of cortisol. And one of the exclusion criteria is that patients must not have increased 24-hour urinary-free cortisol excretion, which would point more towards overt clinical Cushing syndrome. And there's certain other exclusions, such as bilateral tumors, or if patients have another reason to undergo surgery. Primary outcomes are improvement in blood pressure, and that is measured by repeated 24-hour blood pressure monitoring. And improvement in blood pressure is defined as patients being able to stop their medication, reduce their medication, or if they were normotensive to start, that they remain normotensive during the study period. And we also look at several secondary outcomes, such as improvements of other metabolic parameters, diabetes mellitus, improvement of BMI, and other risk factors for atherosclerosis and cardiac function, as well as the rate of patients who undergo surgery of postoperative adrenocortical insufficiency. The study period is 2 years, and following randomization, initial blood tests, patients undergo once more confirmatory tests and a thorough assessment, including glucose, lipids, bone, heart, cardiovascular markers, DEXA scans, and various health questionnaires. Then there's a clinical and biochemical assessment after 3 and 6 months, and an assessment for primary and secondary outcomes at 1 year and 2 years. So the patient I mentioned earlier at the beginning was randomized to surgery, and she underwent an uncomplicated right laparoscopic adrenalectomy in November 2019. Histology showed a benign lesion, although there was some focal nuclear atypia. She had a normal short synaptic test on day 2, so did not require cortisol supplementation following her surgery. When she had a repeat overnight dexamethasone suppression test and low-dose dexamethasone suppression test, you can see that she now fully suppresses her cortisol after dexamethasone administration, and her ACTH also fully normalized to 34. And importantly, she became normotensive without any antihypertensive medications. And if you look at 2 24-hour blood pressure measurements, the first one in 2019, when she was still on 2 antihypertensives before undergoing surgery, so her mean systolic and diastolic blood pressure 120 over 65, and of any antihypertensives in 2021, so that was last month, actually her blood pressure was 102 over 54. She had sustained weight loss, which, and the last measurement here is from the end of September this year. And this is her most recent bone densitometry scan, and you can see a 2.5% increase in her lumbar spine bone mineral density. So all of that looks very reassuring, but of course it is only one patient. But the important thing to say here is also that this patient would not have been offered surgery, because we haven't got a clear recommendation to offer her surgery had it not been for this clinical trial. So in summary, autonomous cortisol secretion is a common phenomenon and affects about 10% of all adrenal incidentalomas. It does not progress to overt Cushing syndrome, and therefore the diagnosis can be really challenging. Overnight dexamethasone suppression test is the gold standard, but we need an additional test to make the diagnosis, and always need to be aware that there's a high false positive rate. So far, there's no robust evidence that a reversal improves cardiovascular outcomes, and the current recommendation is to treat aggressively metabolic risk factors. And just put up this final slide to thank my collaborators, in particular Professor Bergenfeld, who initiated this study, as well as Professor Palazzo at Hammersmith Hospital. Thank you.
Thank you very much indeed. That was fascinating, and that patient's done really well. Has anybody any other questions? Oh yeah, I'm just put the code in the chat. I'll just move that sideways. So one of the difficulties of surgery is to prove that patients actually will benefit. You have to undertake this kind of randomized controlled trial. And the problem is that for each center, the number of patients is too small to reach significance. So unless you have an international study and get lots of centers on board, you're not going to have a study powered highly enough to answer this kind of question. But that...
Well, yeah, no, that's exactly right. And actually it all started before COVID, actually a couple of years before COVID, and everything came to a halt. And many of the other centers still haven't started recruiting yet. So the centers in Sweden have just restarted, and we have just restarted. So I hope we can complete the trial.
Very good. Thank you very much. If there's no other questions, I'll say thank you all for attending. And what's on next week, Liz? Is it Hammersmith?
Yeah, it's Hammersmith. I'm being incompetent here. There's a cancer case, and I'm working on the other case. There will be 2 cases.
Okay, marvelous. Thank you very much. Just to say to everybody also, I mentioned a couple of weeks ago about that petition. So we're over 10,000 now, which is thanks to a lot of you, which is 10,000 and something, 74. So that will get a government response at some point, I hope. Oh, 10,100. Okay, so thank you very much all.
Well done.
See you next week.
Cheers.